to you about our study that was done in conjunction with Dr. Amin and Dr. Goldberg on evaluating the impact of frailty on peri-procedural complications and mortality among patients with GI bleeding. To provide some background, frailty is defined as a clinical syndrome where there is a decline in function across various organ systems, together with an increased risk of poor outcomes in individuals when they are exposed to an apparently innocuous or harmless stressor. So in simple terms, it is a syndrome of increased vulnerability to a stressor. Studies have shown frailty to be a robust indicator of clinical endpoints. Specifically, it has been shown to predict adverse outcomes and mortality with regards to cardiac procedures and surgeries that include PCI, percutaneous coronary intervention, colectomy, and pancreatoduodenectomy. As a result, there have been increased efforts to incorporate frailty measurement tools into clinical practice, which are still ongoing today. However, many of these frailty measurement tools that have been developed and validated have inherent barriers to their use in the acute care setting. Generally, these barriers arise because the tools are either too complex or have some sort of manual evaluation process. And this, of course, limits their application for hospitalized patients. On the flip side, though, there are frailty scores that offer a low-cost, systematic way to screen for frailty and to risk stratify patients. One of these tools is the Hospital Frailty Risk Score. This score was developed in the UK based on ICD-10 codes and was validated against two well-established clinical measures of frailty, the Fried phenotype and Rockwood Frailty Index. Using the Hospital Frailty Risk Score to define frailty has been shown in several subsequent studies to be a prognostic marker of poor clinical outcomes. This has been illustrated in patients undergoing PCI, spinal surgery, and cardiac arrest. It was also demonstrated to be a clinical predictor of mortality and infections after immunosuppression in IBD patients. Now, what about the relationship between frailty and outcomes in patients with GI bleeding or who undergo endoscopy? Frankly, there isn't much in the literature, and only a few studies have looked at frailty associations with GI-related diseases and procedures. In fact, there's only been one study to date looking at the association of frailty as a way to assess patient risk related to endoscopy. In this investigation, Talbot et al. Showed that compared to age and Charlson Comorbidity Index, frailty status was a better predictor of colonoscopy outcomes in older adults. In our study, we aim to use the Hospital Frailty Risk Score to determine the association between frailty status and complication risk in hospitalized patients with GI bleeding who underwent endoscopy. Our hypothesis was that frailty would be a strong indicator of adverse events and all-cause mortality among this patient population. We used data from years 2016 to 2017 of the NIS National Patient Sample. Using discharge ICD codes, we selected for patients with upper GI and lower GI bleeding who underwent endoscopy, either upper endoscopy or colonoscopy within the first 2 days of admission. Then we generalized hospital frailty risk scores to classify patients as frail versus non-frail and determine which patients suffer from peri-procedural complications. For our analysis, we used univariable and multivariable logistic regression models to determine the association between frailty and peri-procedural complications, including mortality. We also performed marginal standardization analysis to assess for possible interaction between age and frailty. Table 1 shows our study demographics. I'm not going to go through each of these individually, but the main point here is that we can see that frail patients have a significantly higher comorbidity score than their non-frail counterparts. In terms of differences in peri-procedural complications as seen in Table 2, we found that frail patients suffered significantly more complications than non-frail patients across all categories, except for drug-related adverse events. Also, frail patients had higher all-cause mortality rates during hospitalization, over a 10-fold increase in this regard. A multivariable analysis as shown in Table 3, where we adjusted for potential confounders, including age and Charlson Comorbidity Index. Our results showed positive frailty status was associated with 2.13 times increased likelihood of having composite peri-procedural complications. Finally, in marginal standardization analysis, we wanted to see if there was a potential interaction between age and frailty. But as demonstrated in the graph, we found that there was a consistent absolute increase in complications for frail patients irrespective of increasing age. In conclusion, our study suggests that frailty status is associated with increased peri-procedural complication, including all-cause mortality during hospitalization for patients with GI bleeding or undergo endoscopy. The underlying significance of these data is that the use of frailty assessments can serve as a guide in clinical decision-making when considering endoscopy and complication risk in patients with GI hemorrhage. We know this is a major decision point in the management of GI bleeding, as we are often faced with deciding which patients should or should not undergo endoscopic procedures for evaluation and or therapeutic purposes. Future efforts in this aspect should be focused on developing a rapid clinical calculator that can further aid in the decision-making process. Since the Hospital Frailty Risk Score involves a large number of ICD codes, this tool would ideally translate it into a more readily available format to help inform clinicians. Thank you for your time.